Wow. Well, good morning, everybody. Such a great start to the morning. What an amazing overview of the field. That was a real pleasure to be able to watch and to digest. I'm Dan Pollyea from University of Colorado, and got my start here in the state of Indiana as an undergrad at Indiana University. So it's good to be back in the Hoosier State. So let's see. Can you guys see my slides? Oh, great. Thanks. There we go. Okay. So great topic I was asked to speak on. Treatment options for newly diagnosed AML patients. And so thought this might be a good way to start the meeting. Quote from Dr. Einstein, not a hematologist, but I think appropriate for this topic here. Everything must be made as simple as possible, but not simpler. So we'll try to stick to that mantra as we go, because I think it's important. I think this is a complicated field, but I think sometimes we overcomplicate things. So we'll get into that a little bit. So I was going to follow the framework of the NCCN guidelines for the purposes of this talk. So we'll keep coming back to these guidelines pages because I think it does organize the thought processes for AML quite well. So we're going to start by talking about intensive induction eligible patients. And for this group, we divided up the favorable risk patients into two different categories. So there's favorable risk as per cytogenetic subsets, the core binding factor AML. But then we also divided this into a favorable risk group by genetic mutations, and here mostly NPM1 and CEBP alpha. And the reason we did this will become clear in a minute, but let me just take you through a descriptive case for this category. So this is a 35-year-old female, history of appendicitis who had an appendectomy, diagnosed with CD33 positive AML with an inversion 16 and a mutation in WT1, and has a performance status of 0. So a lot of times, in med school residency, when you learn about AML, this is the kind of case you're taken through because these patients do so well, they can be cured, quite dramatic clinical course. We, of course, know that this is not the typical patient with AML by any means. These are, that the median age of this disease is 68, and they're more likely to have evolved from an antecedent MDS. But all the same, for this patient, the recommendation would be 7+3 with gemtuzumab, get this patient into first remission, and then consolidate with a gemtuzumab-based regimen. We would then monitor this patient without a transplant in first remission. The rationale here is that, yes, intensive chemotherapy, although it's been the historical backbone of treatment of AML for decades, it is toxic and it is risky. And so, but this is a patient that not only can tolerate it, at least on paper, but also can potentially be cured without a transplant. And so that's why this would be prioritized in this situation. And here's some of the rationale for the addition of gemtuzumab to a core binding factor AML patient. This is a meta-analysis, which we have very few of in our field, in the AML field. But this showed that with a relatively large population of patients, a survival benefit with the addition of gemtuzumab to the favorable risk cytogenetic group, but less of a benefit in the intermediate risk group, and certainly no obvious benefit in the adverse risk group. So in that second subset of favorable risk patients, we divided into core binding factor AML and then favorable risk by other means. And here mostly, again, we're talking about NPM1 and CEBP alpha mutations. Is it the same? Do you get the same benefit from adding gemtuzumab to these groups? And really the answer is probably not from a survival perspective. This came out last year, or 2 years ago now, showing no real difference when you add gemtuzumab to this group. There is, however, potentially or a clear benefit with respect to reduction in relapse risk. And so it's certainly justifiable to add gemtuzumab to this category of patients, but not as highly recommended as it is for the core binding factor patients. Okay, so moving on down the list, these are again intensive induction eligible patients. And here we're talking about AML patients with a FLT3 mutation. And this is a relatively new development in the last year or so with the advent of quizartinib, another FLT3 inhibitor. And so we're routinely using quizartinib in this setting, upfront, newly diagnosed, induction eligible patient with a FLT3 ITD mutation, that's very important, based on this randomized study showing benefit compared to 7+3 alone. Now, this current standard of care before the advent of this study was to use midostaurin. And this quizartinib study was not compared to midostaurin, so take that with some consideration. But the toxicity profile of quizartinib has been, in many people's opinion, better. And so many people are using this more frequently, including at our center. But you do have to remember that this is only viable for patients with a FLT3 ITD. Patients with a FLT3 TKD really still would need to get midostaurin. So that's an important consideration there. Okay, and then moving into the poor risk groups, the adverse risk groups for intensive induction eligible patients, the first category I wanted to focus on are those with either therapy-related AML or those with secondary AML, so AML from an antecedent hematologic condition. Mostly we're talking here about MDS. And for this group of patients, the recommendation is to use CPX-351. So this is the liposomal formulation of cytarabine and daunorubicin. And this is a longer-term follow-up of the original CPX-351 randomized study. I apologize, the colors are flipped here. And so the CPX patients are the ones with the superior survival, even with longer-term follow-up. Now, I think when we start to look at the right side of this curve, nobody is happy or satisfied with these types of survival numbers, but I think it's clear that there is persistence in the survival benefit of CPX-351 compared to 7+3. And this may have something to do with more patients getting to transplant and also patients doing better after transplant if they've had CPX-351 over 7+3. So then as we move down the list, the next category in the adverse risk group would be those patients who have poor risk AML, but here without a P53. So first let's just talk about this group of patients because the NCCN committee thought it was important enough to isolate out the poor risk AML patients with and without a P53 mutation. I'm going to cheat a little bit and not really talk about the P53 mutant patients, and that gives you some sense of how the field is with respect to this subset. We really don't have anything that we're really excited about right now. There's no certainly commercially available standard of care that we would recommend. These are patients that we would all recommend enroll in a clinical trial. And so I think hopefully in a few years someone can stand up on this podium and talk about some exciting developments in patients with P53 mutations, but that's still yet to be in the future. So what do we do about patients who are poor risk but not P53 mutant? So this is where some opinion comes in. In this case, my preference would be venetoclax plus azacitidine, and I'll tell you a little bit about why. And this would, in my view, apply even to those patients who may be candidates for intensive induction chemotherapy. And so if you look at the first survival graph, this is our attempt to plug venetoclax-treated patients into the standard ELN risk group categories. And you can see that, yes, there may be a favorable risk group that you can pull out of that type of an analysis, but the intermediate risk and the adverse risk patients really don't differ. when you use ELN risk categories to try to prognosticate for venetoclax-treated patients. And if you want to focus on it pulling out a good risk favorable group, then please let your eyes go down to the bottom table, and you can see a striking minority of these patients actually do meet requirement for favorable risk. So only 35 of this large data set even met the criteria. So, that's all to say that ELN is just not a good way to risk stratify patients getting venetoclax-based therapies. And, I think it's, if you think about it a little bit, it can be fairly obvious why this is. The ELN used patients who were almost all younger than 60 and almost all treated with intensive induction chemotherapy to pull out risk assessors or prognostic factors. And that just doesn't apply to a totally different therapy. Venetoclax has a different mechanism. And so you would expect it to have different prognostic factors that are applicable here. And so when we attempted to really think about this and develop a separate risk model for venetoclax-treated patients, we sort of started at the end. We just took all the patients that we had access to that were treated with venetoclax HMA, and we made a survival curve with 3 distinct groups. And then we looked to see if we could layer on molecular and or cytogenetic data that would allow us to prognosticate any of the differences between these 3 different groups that were already defined just by their survival. And when we did this, it became very clear there's only 4 genes that were necessary to sort these patients into 3 very distinct survival groups. So the top group, the favorable risk group, you get into just by the absence of P53, KRAS, NRAS, or FLT3 ITD. The bottom group, the adverse risk group, you get into only if you have a P53 mutation. And then the intermediate risk group is just absence of a P53, but presence of either NRAS, KRAS, or FLT3 ITD. So it's a fairly simple 4-gene classifier. And the reason I took you through all that is to say that in that previous example from the NCCN guidelines where you have adverse risk but not a P53, for venetoclax-based, for the new risk classifier, that would put you into either the favorable or intermediate risk groups. And while this does not compare patients to intensive chemotherapy, I think those are if you just look at those curves, those would be equivalent to what you might expect with intensive induction chemotherapy, but without that toxicity. So there are some early efforts to actually randomize patients to receive either venetoclax or intensive induction chemotherapy. This is presented by a Chinese group at ASH this past year. They did just that. These are all younger patients, but they were randomly assigned to one or the other treatments. In this case, it was venetoclax plus decitabine, and you can see no differences in EFS or overall survival. So, I think the day is coming, as was suggested in the introduction here, when we may be doing this a lot more routinely, not putting a patient into intensive induction chemotherapy, even if they could tolerate it. Okay, moving on to the lower intensity groups. The first assessment that we on the guidelines committee said was important was to determine if a patient has an IDH1. And the reason for this is because of the availability of ivosidenib, which we'll talk about in a few minutes. But let me just show you this case to sort of describe this a little bit. 83-year-old woman, history of stroke, hepatitis C, hypertension, recent pneumonia, diagnosed with AML with a normal karyotype and an IDH1 mutation. Her performance status is 3. She's not going to be a candidate for intensive induction chemotherapy. And so when thinking this through, you could use venetoclax azacitidine or you could use ivosidenib azacitidine. And the rationale is that both of these compared to aza alone are superior. And there's no head-to-head competition comparison that's been done between these 2 different therapies. So both are reasonable options, and let me show you why. So here's long-term follow-up of the VIALE-A study. So it shows an ongoing superiority over azacitidine, but not much of the tail. So venetoclax-based regimens, great, good to get patients into a remission, but really not curing the vast majority of patients. And here are the response rates. I usually think of this as somewhere around 60-70% overall response rate. And as most of you treat this disease know, it works quickly. So median time to response, usually about 1 cycle is what you can expect. Now, we pulled out an analysis early on of how do IDH patients do with venetoclax-based regimens. And the bottom curve is azacitidine. You can kind of disregard that. But the top curve, the black curve, are the patients with IDH1 and IDH2 mutations. And then the second analysis is just IDH1 mutations. So IDH mutations overall do better than IDH wild-type patients. Do IDH1 mutant patients do better? When you think about the median survival here that we showed with relatively small numbers, 33 patients, a 15-month survival, it may not be a subset that does much better than IDH wild-type patients. And so the overall benefit here might be really what we're seeing is from IDH2 mutant patients and maybe not the IDH1 mutant patients. So the AGILE study was published several years ago now, randomizing patients between azacitidine and ivosidenib plus azacitidine. And the primary endpoint there was event-free survival. Response rates were very good, equivalent, I would say, to venetoclax azacitidine. The median time to remission may be a little bit longer than it is with venetoclax, or this may be sort of a variation in just the study design and when patients got their bone marrow biopsy to assess the response. But the median overall survival is certainly better than azacitidine, as you can see. And if you kind of just compare this median overall survival to the VIALE-A median overall survival, it would be better. Now, of course, we can't do that, but it does make you wonder what a head-to-head study would look like for these for IDH1 mutant patients who would get venetoclax azacitidine versus ivosidenib azacitidine. So I think that's why where we are at the field right now is either is fine, and people have their their personal practice preferences. The toxicity profile is different. So the ivosidenib regimen is not as myelosuppressive as the venetoclax regimen. And so that may be a reason based on a patient or a practice setting to choose one or the other regimen. And then I just want to point out that this logic does not apply to all targeted therapies. So, just showed you a well-designed study, randomized study, showing Ivo-Aza is better than Aza alone. We can't say the same for enasidenib, the IDH2 inhibitor, or for gilteritinib, one of the FLT3 inhibitors. So both of these studies in a randomized fashion, smaller, sort of non-registrational studies, but still in a randomized fashion, neither of these studies were able to show superiority over azacitidine alone. And so while ivosidenib azacitidine is an option for an IDH1 mutant patient, you really shouldn't be thinking about this for enasidenib, for IDH2 mutant patients with enasidenib, or right now for gilteritinib if you have a FLT3 mutant patient. So that's why the carve-out in the NCCN guidelines really only applies to the presence of an IDH1 mutation, and then everything kind of flows from there. So the NCCN guideline recommendations for a patient with an IDH2 or FLT3 mutation who's not a candidate for intensive induction chemotherapy would therefore be a venetoclax HMA regimen, basically by that logic. Yeah, that's my last slide. So thanks so much for your attention.